This is a case that have the history of the problem of the nasolateral duct obstruction. We have done endoscopic tracheostomy on the left side for 3 weeks, and this is a picture show on the left side. When you take a look, this is show the slit lamp show the position of the silicone tube is in a very good position on the left side. The video that I would like to show today about how to follow up the patient at 3 weeks. Apparently that when we put the slit lamp, it showed that by the normal picture, it show upper eyelid and the lower eyelid and the tube in the good position. When I put the fluorescein, we can see that the cornea is clear. In some cases, the cornea may touch to the tube. They have the keratitis and punctate keratopathy on the inner aspect of the cornea. The patient may feel some itching and feel uncomfortable. This is on the right side, that's a normal side. And beyond that, we need to flip the eyelid inside out. This is on the right upper eyelid. You can see significant posterior blepharitis or meibomian gland dysfunction, and they have a lot of debris, and the bacteria and the demodex is a lot. And let me show you on the left side. And when we flip the eyelid inside out, this is another issue separated from the nasolateral duct obstruction. You can see that she have the significant meibomian gland dysfunction. 1, 2, 3, 4, I would say 3 to 3.5. And when we take a look to the eyelashes, you can see the cylindrical dandruff and significant debris. And when we take a look to the lower lid margin, you can see this is an epithelial ridge and represent the debris, and we call biofilm on the junction between the mucocutaneous junction. This is a elevated ridge that we call debris, and this one need to be clean and not allowed to start on the lid margin, because inside they have the toxic free fatty acid. If we leave like that, even though after the successful endoscopic DCR, this one gonna toxic to the eyelid and toxic to the gland and initiate the secondary posterior blepharitis or meibomian gland dysfunction. So it's our job to explain to the patient the lacrimal surgery have been done successfully. That's easier, but the issue to take care of her eyelid on the upper eyelid, eyelashes, root of the eyelashes, and clean the bacteria and the demodex and clean the lid margin is going to be very, very important. And the next one, I'm going to show you about how to clean her eyelashes, how to clean the eyelashes properly. This is the video that show her lower eyelid on the operated side. And it's very important for the surgeon that to inform the patient to clean the eyelid. And you see, I use a cotton bud, the Q-tip, and inverted the lower eyelid and clean. Because if we or the surgeon or the ophthalmologist not clean for the patient may not be able to clean because they don't see the eyelid by the microscope. They did not know how important to clean the toxic free fatty acid or the debris over here. So if we left like that, the patient will lack the opportunity to protect the eyelid, to protect the meibomian gland. The process of the chronic inflammation of the eyelid gonna be there and continue worse for the meibomian gland dysfunction. Okay. Next one, after I clean her lower eyelid, I need to do the pooling test. The pooling test is mean the test that the ophthalmologist sit by side on the microscope and let the eyelid so dry and grab and pull the one of the eyelashes. If you have the very good microscope, you can pull out the eyelashes and you can show them in front of the microscope to see the big bump, big the debris and all the cylindrical dandruff that we pull out from the eyelashes. And the next step, we put the slide in the microscope. And in this microscope, you're gonna see the body of the Demodex. And this is a video that show in the 40 times with the digital microscope that I put and show to the patient. And it's very important and very powerful to pull the eyelash and show the patient in the computer in the examination room. This is a mature body of the Demodex, and the long one is the lava one, the one that not mature yet. And the clump is have the combination of the old lipid, and that one is going to be one of the toxic free fatty acid. If you zoom in the body of the Demodex, you're going to see this is about the 4,400 times to see the body of the Demodex. Let me show you. This one not that so clear. We come back to this one. Okay, this one is more clear to see. And you're gonna see this is the slide that we left for maybe 1.5 hours. If we just put the slide immediately, we're gonna see the active movement of the leg of the Demodex. And this is a slower because we put the slide and left for many hours. So it's a movement of the Demodex is slower. That's a part of the eyelid that we need to do care for the patient. And the next step, I will show you about how to examine the nasal endoscope and how to take the tube out for you. Okay. This is the video that we use the nasal endoscopic view to see post-op at 3 weeks. This is an inside nasal cavity. We approach from the nasal ostium to the nasal ostium. This is a video show that the stitches of the stent that we fix to the lateral nasal cavity. And after that, you see that the tube in the good position and the nasal ostium in the beautiful contour and shape. And look, the patient see it look very well, and you can see. And the next step, I will do the lacrimal syringe. We put the numbing drop for her eye first, and if you feel numb enough, we do the lacrimal syringe. I try to pass the water from the eye to the nose. Next step, I will start from the upper tear duct first, because if we start from the upper tear duct, it will be easier than we start on the lower tear duct because the curvature of the canalicular system from the punctum. And this video show very easy to do the lacrimal syringe. You can see that the tip of the syringe can be passed freely, and you can pass through from the lacrimal upper part of the lacrimal syringe, and you can see the water could be flow 100% without the resistance. And I ask the patient to feel if she feel the water or not, and she can say that the water could be flow easier. And the next one we can prove by use the endoscope inside to see the tip of the lacrimal syringe. And you can see that some movement because of the tip of the needle. And after that, when we see this one, you can see the tip and you can see the water will be passed through. And the next step, after that, we use the scissor and the simple scissor and the forceps to grab the silicone tube. Personally, I always cut at the loop between the upper and lower eyelid, and then we cut the stitches that we fit to the lateral nasal wall cavity. And after we take the 5/0 suture out, we can relieve the nasal clog, remove the nasal clog, and we can gradually remove the silicone tube easily. This is the step that we take the 5/0 out. And we can see that this is a nasal to do the silicone removal. After that, we can see the piece of the silicone stent. Sometimes we can see the nasal discharge surrounding the silicone stent. It's very important to clean after weekly after the surgery, because if the nasal clot has been stuck for a long time, sometimes it makes the inflammation, it makes the granulation. And this one is show the upper and lower opening of from the upper and lower canalicula. In this case, you can see the opening. And the next few seconds, I will show you how to put the syringe to the lower of the tear duct and see the tip of the needle coming out. You can see that the water could be flow easily.